Welcome to the deep dive. Today we're getting into something specific, carotid artery dissection, CAD for short.
That's right.
We've gone through quite a bit of medical textbook material, really trying to distill what's crucial about this condition,
Yeah.
What it is, why it might happen, how it's diagnosed, and how doctors are treating it these days.
And it's an important one. You might not hear about CAD all the time, but it's actually a pretty significant factor in strokes, especially for younger adults, which is, well, quite surprising to many.
Exactly. That really caught my attention, too. And it's not just about, say, dissections after a major car crash or something.
Well, not at all.
We're also looking at these spontaneous cases, the ones that seem to, well, happen out of the blue, alongside the trauma-related ones. So our mission here really is to pull out that expert knowledge and lay it out clearly, maybe bust a few myths, and just help you get a solid understanding of what really matters with CAD.
Sounds good.
Okay, so let's dive right in. What exactly is a carotid artery dissection?
Fundamentally. Okay, so picture the main arteries in your neck, the carotids, bringing blood up to your brain. A dissection is basically a tear that happens in the inner lining of that artery wall.
A tear in the lining.
Right. The wall has layers, like an onion almost, and this tear lets blood get between the layers.
Oh, okay.
It leaks in and starts to collect there, forming what we call an intramural hematoma. Think of it maybe like a blood blister, but forming inside the artery wall itself.
A blood blister inside the artery wall. Yeah, that paints a picture.
Right.
And does this happen in a specific part of the carotid?
It can happen in two main areas. More commonly, it's in the part of the artery outside the skull, the extracranial part.
Okay.
But it can also occur inside the skull, the intracranial part. That's actually seen a bit more often in children and also in people of Asian descent.
Interesting distinction.
Yeah.
And what are the downstream effects? I mean, what problems does this internal tear and bleeding cause?
Well, that collection of blood, that hematoma, it takes up space, right? So it
Yeah.
can squeeze the main channel where the blood is supposed to flow.
Right.
That narrowing is called stenosis. Sometimes it can squeeze it shut completely. That's an occlusion.
Like kinking a hose, then clamping it shut.
Exactly. Or the weakened wall can bulge outwards, forming an aneurysm, like a weak spot in a tire.
Okay.
And there's another big risk. The tear itself, that injury to the artery lining, can trigger clotting. So you might get a blood clot forming right there. That's acute thrombosis.
Which is bad enough on its own.
Right. Or even worse, a piece of that clot can break off and travel up into the brain.
Causing a stroke.
Precisely. That's cerebral embolization, and it's a major concern.
Wow, okay. That sounds quite serious indeed.
Huh.
Now, let's focus on these spontaneous dissections you mentioned, the ones without an obvious big injury. How common are we talking?
Yeah, spontaneous CAD, where it just seems to happen. It's considered rare. The numbers usually quoted are around 2.6 cases per 100,000 people per year.
So not common cold territory.
Definitely not. But there's a feeling among some experts that the actual number might be higher.
Oh, why is that?
Because some dissections might cause very mild symptoms, or maybe none at all, so they just go undiagnosed. Silent cases, you know.
Right. So it could be lurking more often than the stats show. And who typically gets these spontaneous ones? Is there an age group?
The average age when it's diagnosed is around 45. So middle age generally.
Okay.
And it seems to affect men and women roughly equally overall. But there's an interesting observation in some studies.
What's that?
Women who get spontaneous CAD, they tend to be diagnosed at a younger age than the men, and they might also be more likely to have dissections in more than one artery when they're found.
Huh. That is interesting. So, okay, let's get into the mechanics. What's actually happening inside the artery wall during one of these spontaneous events?
Fundamentally, it's that separation of the layers we talked about. This creates a kind of false channel or potential space within the wall.
Right, the space for the hematoma.
Exactly. Blood leaks into this false channel. Now, what starts the bleeding isn't always 100% clear. It could be a tiny rupture of the very small blood vessels within the artery wall itself. Well, those are called the vasa vasorum.
Little vessels feeding the big vessel wall.
Sort of, yeah. Or it could start with a tiny tear, an initial rip in the innermost lining, the intima.
Okay. And I've heard terms like subadventitial and subintimal dissection. What do those refer to?
Ah, good question. That just tells you where between the layers the main separation is happening.
Okay.
Subintimal means it's just under that innermost lining, the intima. Because it's right next to the main blood flow channel, it's more likely to press inwards and cause that narrowing, the stenosis.
Right, the kinking.
Whereas subadventitial means it's closer to the outer layer, the adventitia. These are more often linked with the wall weakening and bulging outwards to form an aneurysm.
So location matters for the outcome. Got it.
Yeah.
And does the body try to heal this internal damage?
It does, yeah. When researchers have looked at tissue samples, they see a kind of healing process unfold over time.
What does that look like?
Well, first you have the bleeding, the hematoma. Then, after about 2 weeks or so, the body starts bringing in repair cells and forming new connective tissue, granulation tissue, trying to shore things up.
Okay.
The inner lining along that false channel also tends to thicken up. And then maybe after about a month, you start to see tiny new blood vessels forming within that thickened area. That's called neovascularization. So yeah, there's definitely an attempt at repair.
That's good to know. But why do some people get these spontaneous tears in the first place? What makes their arteries, I guess, vulnerable?
That's really the key question, isn't it? The general thinking is that there has to be some kind of underlying, maybe subtle weakness or fragility in the structure of the artery wall itself.
So not just bad luck.
Probably not entirely. It seems this inherent fragility makes the artery more susceptible to tearing, even under maybe normal or slightly increased stresses. Interestingly, about 40% of people do report some kind of physical event beforehand, but often something seemingly minor.
Like what sort of minor events? People worry about things like chiropractic adjustments.
Well, yes, things like chiropractic neck manipulation, even vigorous coughing, sneezing, or vomiting have been reported in association with some cases.
Right.
But large-scale research hasn't consistently proven a strong direct cause and effect link for those specific things. It's still debated.
Okay, so the jury's out on some of those. What has been more clearly linked?
What seems to hold up more strongly as independent risk factors are things like having had a recent infection, having high blood pressure, arterial hypertension, and also having a history of migraine headaches.
Wow, infection and migraine. That's unexpected.
It is a bit, yeah. But those associations seem pretty consistent in studies.
And are there things that people might think are linked but actually aren't, according to the evidence?
Yes, good point. Studies have generally not found a significant link between spontaneous CAD and things like a history of smoking, having diabetes, having atherosclerosis, the typical hardening of the arteries, or using oral contraceptives.
Okay, that's helpful to clarify. So if someone is having a spontaneous dissection, what are the key warning signs? What should they or people around them look out for?
The most common symptoms by far are headache and neck pain. Headache pops up in something like 80% of cases.
80%.
Yeah, it's very common. It can come on gradually, but for maybe 1 in 5 people, it's a sudden, severe onset headache, sometimes called a thunderclap headache.
Okay. And neck pain too.
Yes, often on one side. Then there's Horner syndrome. That occurs in nearly a quarter of patients.
Remind us what Horner syndrome involves.
Sure. It's a combination of a drooping eyelid, a smaller pupil in the same eye, and sometimes decreased sweating on that side of the face. Interestingly, with internal carotid dissection, it might just be a partial Horner's, just the eyelid droop and small pupil without the sweating changes.
Got it. What about more obviously neurological things, signs the brain isn't getting enough blood?
Absolutely crucial. TIAs, transient ischemic attacks, or mini strokes and full-blown strokes, cerebral infarctions, they happen in over half the cases, around 56%.
That's a huge percentage.
It is. It highlights why CAD is a serious cause of stroke, especially in this younger demographic.
Right. Any other signs? Eye problems?
Yes, definitely. You can get eye pain, sometimes sudden but temporary vision loss, maybe from reduced blood flow to the optic nerve, unequal pupil sizes, what's called anisocoria, and brief episodes of blindness in one eye, like a curtain coming down, that's amaurosis fugax.
Okay.
And in those rarer cases where the dissection is intracranial, inside the skull, it can unfortunately lead to bleeding around the brain, a subarachnoid hemorrhage. That usually has a pretty poor prognosis.
That sounds very dangerous. Are there any other, maybe less common symptoms to be aware of?
Yeah, there are a few others. Sometimes the dissection can actually affect the cranial nerves, the nerves controlling face, throat, tongue muscles. That happens in about 12% of cases.
With your nerves specifically?
Often the lower ones, like nerves 9 through 12. A classic example is weakness of the tongue muscle, the hypoglossal nerve, nerve 12. If you ask someone to stick their tongue straight out, it might deviate towards the side of the nerve injury.
Huh.
You might also see changes in taste, difficulty swallowing or speaking, maybe even a drooping shoulder if the accessory nerve is involved. And some people will report hearing a pulsing sound in their ear, synchronous with their heartbeat that's called a brute, or just ringing in the ears, tinnitus.
Okay, that's a very thorough picture of the spontaneous side.
Yeah.
Let's shift gears slightly to traumatic carotid artery dissection. The cause seems more obvious here, right? Injury.
Exactly. Traumatic CAD is caused directly by, well, trauma to the neck. That could be forceful blunt trauma, like a blow, or a sharp penetrating injury, like a stab wound.
And what kind of forces cause the tear in blunt trauma?
Often it's due to rapid deceleration, the kind you see in motor vehicle accidents.
Whiplash-type forces.
Yeah, or forces that cause severe neck extension bending way back, or sharp lateral flexion bending sideways, or rotation twisting. These sudden, forceful movements can stretch or shear the artery lining.
Makes sense. Are there other types of blunt trauma besides, say, car accidents?
Oh, yes. Injuries directly to the mouth cavity can sometimes transmit force. Also, fractures of the jawbone, the neck vertebrae, or the base of the skull are high-risk injuries for associated CAD.
Right, the artery runs right past those structures.
Precisely. And unfortunately, sometimes dissections can happen as an unintended consequence of medical procedures, particularly those involving catheters inside blood vessels. We call that iatrogenic injury.
Okay. How often does traumatic CAD actually happen?
Looking at all trauma patients admitted to a center, the overall incidence is probably less than 1%, maybe around 0.86% in some studies.
This is still relatively uncommon overall.
Overall, yes. But if you focus specifically on patients who have injuries known to carry a high risk for carotid damage, like those base of skull fractures, or severe neck hematomas,
Then the rate goes up.
significantly. One study, for instance, looked at that higher risk group and found traumatic internal carotid dissections in about 3.2% of them. So much more common in select patients.
Right. And when someone does have a traumatic CAD, how does it show up? Are the symptoms different from the spontaneous ones?
Actually, the symptoms themselves are quite similar. Headache, neck pain, Horner syndrome, stroke symptoms, all the things we discuss for spontaneous CAD can happen with traumatic CAD too.
Okay.
A key difference, though, is that patients might initially be asymptomatic right after the injury, especially if they have other distracting injuries or altered consciousness.
So it might be missed initially.
It can be, but most people will develop symptoms, usually within the first 24 hours after the dissection occurs.
Which really highlights the need to look for it, doesn't it?
Absolutely. That's why there's a low threshold for diagnostic imaging in trauma patients who have specific red flags. Things like active bleeding from the neck, a rapidly expanding bruise or swelling there, a new Horner syndrome, hearing that whooshing sound, the brute, over the carotid.
Or neurological signs.
Exactly. Any signs of cerebral ischemia, stroke symptoms, facial or neck fractures we talked about, or even just an unexplained altered level of consciousness after trauma should raise suspicion for CAD.
Okay, so suspicion is high in certain scenarios. How do doctors confirm it? What are the main diagnostic tools?
Choosing the right imaging test is really important, and it depends a lot on the clinical picture. Is it an emergency trauma situation or a more stable patient with suspected spontaneous CAD?
That makes sense. What used to be the go-to?
For a long time, conventional angiography was considered the gold standard. That involves putting a catheter into an artery, usually in the groin, threading it up to the neck, and injecting contrast dye while taking x-rays.
But you said used to be. Why the shift?
Well, angiography can definitely show some classic signs, like a long, tapered narrowing that looks like a flame shape.
Flame shaped, okay.
Or you might see the torn inner lining as a flap, or a pseudoaneurysm, that bulge we mentioned, or even the double lumen, the true and false channels.
So you can show the problem. What are the downsides?
It has several. It's invasive, obviously. It costs more. And it carries risks. You could dislodge a clot, cause another dissection, or even perforate the artery with the catheter. Plus, risks from the contrast dye for the kidneys and issues at the catheter insertion site.
And does it show the hematoma in the wall?
That's a key limitation. It doesn't directly visualize the intramural hematoma or abnormalities within the vessel wall itself, just the shape of the blood flow channel. So because of all that,
Newer methods took over.
largely, yes. CT angiography, CTA, and angiography, MRA, are now the frontline imaging tools in most places.
Okay, let's talk about MRI and MRA first, often done with something called fat suppression. What are the big pluses there?
The major advantages of MRI are that they're non-invasive, no catheters needed, and there's no ionizing radiation.
Good for safety.
Right. And crucially, they are excellent, really the best, at directly showing that intramural hematoma, the blood collection within the artery wall. That's a key diagnostic feature.
It can actually see the blood blister.
Exactly. You can often see its typical crescent shape on the MRI images. It also shows any narrowing of the lumen, irregularities in the wall if the main channel is pushed aside, and any pseudoaneurysm.
Any other benefits?
Well, being radiation-free makes it safer for children and pregnant women. It's also really good for picking up dissections that aren't brand new, maybe subacute or chronic hematomas. An MRI of the brain can be done at the same time to look for any early signs of stroke.
Sounds pretty good. What are the catches? Are there limitations?
There are a few. Sometimes, in the very, very early stages, right after the tear, the hematoma might be harder to spot definitively on MRA. Availability can be an issue. Not every hospital has an MRI scanner readily available 24/7.
And the scan itself?
It takes longer than a CT scan, which isn't ideal in a time-sensitive trauma setting. Some patients find the machine claustrophobic or can't tolerate lying still for that long. And while it often doesn't require contrast, if gadolinium contrast is used, there are potential risks associated with that too, especially in patients with kidney problems.
Okay. So what about the other main player? CT angiography, or CTA. What does that bring to the table?
CTA is also very good. It can show a characteristic pattern sometimes, like the carotid seems blocked off, flow down, but then you see flow again higher up near the skull base.
The flame sign again.
Similar idea, yeah, a tapering occlusion. It can also clearly show that crescent-shaped thickening of the artery wall, indicating the intramural hematoma. Sometimes you can even see the double lumen sign. Plus, luminal irregularities, pseudoaneurysms, it picks those up well too.
And its advantages.
It's generally very accurate, it's much less invasive and better tolerated than conventional angiography. Crucially, it's faster than MRI and usually much more feasible in an acute trauma situation.
And you can combine it with other scans.
Yes, often a CTA of the neck vessels can be done right along with a standard CT scan of the head, which is almost always needed in stroke or major trauma evaluation. Very efficient.
Makes sense. Downsides to CTA.
Yes. It uses iodinated contrast dyes, so it's contraindicated or needs caution in people with significant allergies or poor kidney function.
And the radiation.
Exactly. It involves radiation exposure, so it's generally avoided during pregnancy and used judiciously in children. Also, if the patient has a lot of calcium buildup, atherosclerosis in their arteries, that can sometimes create artifacts that make interpreting the scan harder. And getting the timing of the contrast injection just right is important for good images, which can sometimes be tricky.
Okay, one more. Duplex ultrasound. The U.S. sounds less high-tech. What's its role?
Don't underestimate ultrasound. It's actually a really valuable tool here. Its big strengths are that it's inexpensive, totally non-invasive, can be done right at the patient's bedside.
Portable.
Exactly. No radiation, no contrast dye risks. It's also fantastic for follow-up imaging to monitor how the dissection is healing over time.
How accurate is it?
In experienced hands, it can be surprisingly sensitive, potentially up to 95% for detecting CAD. It's particularly useful in trauma patients who are too hemodynamically unstable to be moved to the CT or MRI scanner.
What can it actually show?
It can directly visualize the intramural hematoma within the wall. Sometimes you can see the true and false lumens, and it can assess blood flow to detect narrowing or occlusion. Often you'll see very high flow velocities through a narrowed segment.
But it must have limitations too.
Oh, definitely. The biggest one is that it's highly operator dependent. The quality of the scan really depends on the skill of the person doing it.
Right.
Also, ultrasound waves can't easily penetrate bone, so it generally can't detect dissections that are inside the skull. It also struggles to see the vertebral arteries well, or the very highest part of the carotid artery up behind the jawbone. And spotting small, non-flow limiting clots can be difficult.
So a range of tools, each with pros and cons, used depending on the situation. Okay, let's get to the crucial part. Treatment. Someone's diagnosed with CAD, what happens next?
Right. Treatment really has to be individualized. You have to consider the patient's symptoms, their age, other health problems they might have, and whether it was spontaneous or traumatic.
What are the main goals?
In the acute setting, the #1 goal is to prevent brain ischemia, lack of blood flow, and stroke, and also to stop the dissection itself from extending or getting worse.
And what's the general approach?
Generally, based on guidelines like those from the Society for Vascular Surgery, the initial treatment is usually medical. That means using antithrombotic therapy medications to prevent blood clots.
Start with pills or IV meds first.
Usually, yes. If symptoms continue or worsen despite good medical therapy, then more invasive options like balloon angioplasty and stenting are considered. Those endovascular approaches are often preferred over traditional open surgery nowadays if intervention is needed.
Okay, let's unpack that initial medical treatment. What kinds of drugs are we talking about? Anti-clotting meds.
Exactly. The thinking is that the main cause of stroke in CAD is often clot formation triggered by that damaged artery lining. So the cornerstone of medical treatment is either antiplatelet drugs or anticoagulants.
Exactly.
Antiplatelets would be things like aspirin, clopidogrel, maybe dipyridamole. Anticoagulants usually start with heparin, often low molecular weight heparin given as shots followed by warfarin, which is a pill aiming for a specific level of blood thinning, an INR target usually between 2 and 3. Sometimes antiplatelets and anticoagulants are used together, sometimes one or the other.
How long do people typically stay on these?
It varies, but a common duration is somewhere between 3 and 6 months. That's roughly the time frame it often takes for the artery lining to heal significantly.
But not always.
No, some patients might need longer treatment, especially if follow-up imaging still shows issues or if they have ongoing symptoms. There isn't a hard and fast rule on when to stop, unfortunately. It's guided by symptoms and imaging.
Are there downsides to using these blood thinners?
Of course. The main risk with any antiplatelet or anticoagulant is increased bleeding. That's a particular concern in traumatic CAD where there might be other injuries that could bleed. There's also been a theoretical worry, especially with anticoagulants, that they could potentially cause the hematoma within the artery wall to expand, although how often that actually happens is debated.
So is one approach, antiplatelets versus anticoagulants, definitely better?
Well, that's been a big question. Interestingly, major guidelines, like those from the American Heart Association, haven't strongly recommended one over the other as the definite first choice.
Hasn't there been research on this?
Yes, a really important randomized trial called CADIS was published in 2019. It directly compared antiplatelet therapy versus anticoagulant therapy in patients with symptomatic CAD.
And the result?
The bottom line was they found no significant difference between the two groups in terms of the rate of recurrent stroke or death, or even in how often the artery recanalized or reopened.
No difference. That's surprising.
It was quite significant, yeah. So based on TATUS and considering that antiplatelet drugs are generally easier to manage, have fewer monitoring requirements, and are less expensive,
They often get the nod.
they are often favored now as the first-line approach, unless maybe future trials show something different or there's a specific reason in an individual patient to use anticoagulation.
Okay. What about the really strong clot-busting drugs, thrombolytics? Is there a role for those?
Yes, potentially. Thrombolytic therapy, like with RTPA, can be considered if a patient presents with an acute stroke clearly caused by the dissection and they arrive within the standard time window for thrombolysis, usually 3 to 4.5 hours from symptom onset.
Same as for other types of stroke.
Generally, yes. It can be given intravenously or sometimes directly into the artery via a catheter, but
Big risks.
the major risk, as with any thrombolysis, is intracranial hemorrhage bleeding into the brain. That's the biggest worry.
Are there extra risks specific to dissection?
There are theoretical concerns. Could the drug weaken the already damaged artery wall and cause it to rupture? Could it cause the intramural hematoma to expand rapidly? If given interarterially, could the catheterization itself dislodge clot? These are possibilities.
But do they actually happen more often in CAD?
Studies looking back at patients who received thrombolysis for stroke associated with dissection haven't generally shown worse safety outcomes compared to thrombolysis for other stroke causes.
So it's not ruled out.
Not automatically. The American Heart Association doesn't have definitive recommendations specifically for CAD, but another study group, CAD-SP, suggested that if a patient meets the standard criteria for thrombolysis, having an underlying dissection isn't necessarily an absolute contraindication. It's a case-by-case decision, weighing risks and benefits.
Okay. Now, what if the medications aren't enough or aren't an option? You mentioned endovascular treatments. What does that involve?
Right. Endovascular approaches like angioplasty and stenting are definitely being used more, even though we lack those big head-to-head randomized trials comparing them directly to, say, surgery for CAD specifically.
When would doctors consider these?
They're usually reserved for specific situations. For example, if antithrombotic therapy is contraindicated for some reason, like active bleeding elsewhere.
Or if it's just not working?
Exactly. If the patient keeps having symptoms, like TIAs or strokes, despite being on medication, or if there's clear evidence of ongoing emboli clots traveling to the brain, and particularly if there's also evidence of poor blood flow, hypoperfusion to the brain.
What about those aneurysms?
Yes. If a pseudoaneurysm related to the dissection is seen to be enlarging over time on imaging, that's another potential reason to intervene endovascularly.
And what can these procedures achieve? What are the goals?
Well, they can potentially retrieve thrombus from the artery. They can physically open up the narrowed segment, the stenosis, to improve flow. The idea is to restore normal cerebral perfusion and hopefully prevent further emboli. Stenting can also help tack down the dissection flap and sometimes leads to shrinkage or disappearance of pseudoaneurysms over time.
What are the techniques? Balloons and stents?
Primarily, yes. Angioplasty uses a balloon to stretch the narrowed area open. Stenting involves deploying a small metal mesh tube to scaffold the artery open. Often they're used together.
Is there protection against clots breaking loose during the procedure?
Absolutely critical. These procedures are almost always performed using embolic protection devices, little filters or baskets placed beyond the treatment area to catch any debris that might get dislodged.
And after the procedure?
Mm.
More blood thinners.
Patients will typically need to be on antiplatelet medications, often 2 different ones for a period, then usually one long-term. But generally, long-term anticoagulation like warfarin isn't needed after successful stenting for dissection.
Sounds promising. But are there risks with these endovascular treatments too?
Oh yes, they are invasive procedures, so they carry risks. You could potentially cause a new dissection or worsen the existing one. Thromboembolism, dislodging a clot, is always a risk despite protection devices.
What else?
Arterial spasm, the stent itself could clot off acutely. Stent thrombosis, perforation of the artery, the stent could migrate. And of course, the ultimate risk is causing a stroke during the procedure. Longer term, you can get re-narrowing inside the stent due to tissue growth called intimal hyperplasia.
So it's not risk-free.
Definitely not. Reviews of cases where stenting has been done for CAD generally suggest it appears relatively safe and effective in reducing stroke risk in appropriately selected patients. But because the risks are certainly higher than just taking medication, it's reserved for those specific situations we talked about where medical therapy isn't enough or isn't possible.
Right. And what about the most invasive option, traditional open surgery? When does that come into play?
Open surgery is generally considered for similar indications as endovascular treatment, really. Persistent, severe stenosis causing symptoms despite medical therapy, or an aneurysm that's clearly enlarging or newly developed after a reasonable period, say 6 months, of medical management.
Any specific scenarios where surgery might be favored?
One study noted that a common reason surgeons opted for open repair was concern about a distal aneurysm, one located high up near the base of the skull, that might be difficult or risky to treat endovascularly.
What's the preferred surgical approach?
Often, especially in younger patients, the goal is to actually resect or remove the problematic segment, the part with the aneurysm or severe stenosis that might be throwing off clots, and then reconstruct the artery using a vein graft, typically harvested from the patient's leg, the saphenous vein.
Sounds complex. Is it technically difficult?
It can be very challenging. As we mentioned, these dissections often extend quite high up in the neck, close to the skull base, which is difficult surgical territory to access safely, requires extensive exposure.
Are there other surgical options besides grafting?
Yes. Depending on the situation, other techniques might include simply ligating or tying off the carotid artery completely, but only if tests show there's adequate blood flow to the brain from the other side and the patient tolerates a temporary clamping of the artery without issues.
Risky, though.
Can be. Another option is a thromboendarterectomy, similar to what's done for atherosclerosis, where the surgeon opens the artery, cleans out the inner lining and clot, and then closes it, usually with a patch to widen it, patch angioplasty.
How do the risks of open surgery for CAD compare?
Interestingly, the rates of complications, morbidity, and mortality tend to be higher for open surgery for CAD compared to the same types of surgery done for the more common atherosclerotic carotid disease.
Why is that?
Likely due to the often more distal location of the dissection, the potentially more fragile nature of the artery wall in some cases, and the technical difficulty. Complications can include stroke, injury to nearby cranial nerves, and clotting of the vein graft if one is used.
So when is open surgery still the right choice?
It might be the necessary approach for certain penetrating injuries to the extracranial carotid artery, or for specific complex lesions, perhaps involving large aneurysms near the skull base, that just aren't suitable for an endovascular fix. It's definitely less common than medical or endovascular therapy now.
Okay, so it's clear treatment is very much a tailored decision, weighing all these factors. Let's wrap up by talking about prognosis. What does the future generally look like for someone after a CAD?
Well, first off, getting the diagnosis right and getting it promptly is crucial for a better outcome. That's key.
And who might be at higher risk for problems down the line?
The risk of having another dissection, a recurrence, seems to be higher in people with a family history of CAD, and also in those with known underlying connective tissue disorders. We mentioned fibromuscular dysplasia, Marfan syndrome, Ehlers-Danlos syndrome type IV.
Right, the conditions affecting vessel wall integrity.
Exactly. Also, generally the prognosis tends to be a bit poorer if the dissection was caused by trauma, if the patient already had a stroke by the time they were diagnosed, or if there was a significant delay in getting the diagnosis.
Do traumatic dissections behave differently long term?
They do seem to have a higher tendency to form aneurysms and to lead to complete occlusion of the artery compared to spontaneous ones. And perhaps related to that, stroke resulting from CAD often carries a worse prognosis than a typical stroke caused by atherosclerosis.
Okay. What about specifically for the spontaneous cases? What's the general outlook there?
For spontaneous dissections, thankfully, the overall mortality rate is quite low, generally less than 5%.
That's reassuring.
It is, although, as we noted, about half of patients will have a stroke early on, often as the presenting event.
But do things improve?
Yes, the good news is that in roughly 75% of spontaneous cases, the artery narrowing tends to resolve over time as the hematoma heals and remodels. The artery often looks much better on follow-up scans.
And the risk of it happening again? Recurrence?
The recurrence rate is estimated to be around 1% per year, maybe for up to 10 years. It might be slightly higher in younger individuals, so not extremely high, but definitely a long-term consideration.
When is the risk of another stroke highest after the initial event?
Studies suggest the highest risk period for a recurrent stroke is really in the first couple of weeks after the dissection occurs. That risk then seems to drop off significantly after about the first month.
So the immediate aftermath is the most dangerous time.
Seems that way. Looking at longer-term follow-up in cohort studies, the rates of recurrent dissection, new stroke, or new TIA are relatively low, maybe around 1–2% over a couple of years.
So overall, while it's a serious event, especially initially, many people with spontaneous CAD do recover reasonably well.
Many do, yes. But it remains a really important cause of stroke, particularly in younger and middle-aged adults, that we need to be aware of.
Absolutely. What kind of long-term advice or management strategies are typically recommended for patients after they've had a CAD?
The standard recommendations usually focus on reducing potential vascular risk factors. So definitely smoking cessation, strict blood pressure control is vital.
Maintaining healthy BP.
Yes. Also, maintaining a healthy diet. And patients are often advised to avoid activities involving heavy lifting or straining, which could potentially increase pressure or stress on the arteries.
Are specific medications used long-term besides the antiplatelets, BP meds?
Yes, antihypertensive medications are often necessary if blood pressure is elevated. As for other things like cholesterol-lowering drugs, statins...
Is there evidence for statins in CAD?
Currently, there isn't strong evidence specifically demonstrating a benefit of statins for preventing recurrence after a CAD, unlike in atherosclerotic disease. However, given their general vascular protective effects, it's certainly an area that needs more investigation.
Right. Well, this has been an incredibly thorough and really informative deep dive into carotid artery dissection. We've covered a lot of ground, from the basic mechanics to the causes, the nuances of diagnosis, and the evolving treatment landscape.
It's a complex topic, for sure.
It really is, and it hammers home the point that while CAD might be statistically rare overall, its impact, especially as a cause of stroke in younger people, makes it incredibly significant. And it definitely sounds like the medical community's understanding, particularly around the best medical treatments and the role of endovascular options, is still evolving.
Absolutely. Ongoing research is crucial here, constantly refining how we approach diagnosis and tailor treatment to get the best possible outcomes for patients facing this.
So as we close out today, maybe a couple of things for you, the listener, to ponder. First, given this complexity we've discussed, the different causes, symptoms, and the various treatment options with their own risks and benefits, what factors do you think are the most critical for doctors and patients to weigh when deciding on the best path forward for an individual?
That's a great question. Personalizing care is key.
And maybe another thought, considering that sometimes seemingly minor events, or even just underlying fragility, can lead to such a significant vascular injury, like a dissection. What does that suggest to you about the resilience or perhaps the inherent vulnerability of our own vascular system?
Definitely food for thought about how intricate our bodies are.
Indeed. It certainly invites further reflection. And as always, this discussion is for informational purposes. Please consult with your own healthcare professionals for any personal medical advice or concerns. Thank you for joining us for this deep dive.